will start now with the local anesthesia. The tooth we have to extract is the 4.8, and we see that there is a curvature of the roots and an osteorarefaction distally to the tooth. We see that there is pus coming out from the sulcus of the tooth, and we have to know that these teeth, which are already erupted, are sometimes even more difficult to extract in comparison to impacted teeth, because the ligament has completely formed and the chewing pressure on the tooth has created a major attachment between the tooth and the bone, surrounding bone. So local anesthesia that has been performed buccally and lingually with articaine, with a vasoconstrictor 1 to 100,000, we see the swelling of the soft tissue, and then we probe the soft tissue to be sure that the anesthesia has made its effect. And then we have to treat this tooth that had those roots just as an impacted tooth. So we perform a intrasulcular incision of the 7th tooth, and we have seen that pus coming out from the sulcus gives us the sensation that the soft tissues are not going to be quite firm, but they're going to be brittle and not easy to handle. We have to enter our sulcus to the bone level and then a releasing incision, because we know that we have to perform some ostectomy, osteosectioning, and odontotomy and dental sectioning of the tooth. So this is the moment you see that the tissues have a particular inflamed color. They're a little bit more reddish, they're less pink than normal, and the tissues and the area is going to bleed a little bit more than when we have healthier tissues. We use our freer elevator to detach the flap. We have to find the correct under subperiosteal plane in order to protect the soft tissues and the structures that are in the soft tissues. It is very important to find the correct plane in order to reduce the damage and the laceration of the periosteum. So once we found the bone, we have to enter with our elevator and then do that pushing and rotating movement in order to detach a full thickness flap. And you see towards the sulcus that the tissues are now stretching out and are almost ready to be detached. But we know that that tissue is inflamed tissue, and we will have to help out with a tweezer to keep the papilla of the distal aspect of the second molar and to keep it in tension in order to create the correct elevation. So now we start to see the healthy bone, which is apical to the sulcus, where we saw the pus coming out. And now we start stretching the flap. We get our blade and we re-enter to cut the fibrotic and the granulation tissue, which gives us a block in the correct elevation. And as I told you, it will bleed because of the inflammation. And this is obviously a time that we lose in the initial part of the extraction, but it is very important because it gives us the correct plane afterwards to work properly and to avoid any intraoperative complications. So it is always very, very important and mandatory to find the correct working plane. So as you see, I go inside with the elevator and then I start pushing towards the buccal aspect, always with my elevator, and then once I find the correct plane, I can then enter with my Langenbeck retractor and start pushing backwards the flap. And as I saw on the radiograph, that is the area of radiotransparency where there was the infection. And we start to remove that material and part of the buccal bone using a round bar on the straight handpiece. And this is going to be important to start looking for the furcation of the tooth. And as we know, the mesial root had an important curvature, so we start also creating some space using piezoelectric instrumentation. This is a saw insert, which is very performing because it is 0.3 millimeters of width compared to a normal straight bar, which is a Fisher bar, which is usually 1 millimeter of width. So it is very conservative, little bone consuming, but it creates the correct spaces and movements for the tooth to move and for the tooth to rotate in its axis to the extraction. We know that this instrumentation is very helpful and useful also in deep and dangerous areas where we are close to the nerve, because it is very, very safe and very, very conservative and precise. So once we have made this working space, we start with a gentle luxation to see if there is a gentle and light movement of the tooth, but we also see that there is not such a great movement. So we start to remove the soft tissue around the tooth with a Lucas spoon in order to make some space. And then we continue to create a working space, which we can call also piezoperiotomy, in order to go deep around and draw a space around the root block, which is a little bit more apical, and think that if we would do this with a Fisher bar, we would erode and we would remove a lot of bone on the buccal aspect. Another test of the luxation, what we do in these cases, you see that I've exited the Langenbeck retractor to use the lever in order to reduce the possibility of laceration of the soft tissue. And here the patient feels a little bit of uncomfortable sensation, and so we tend to perform a supplementary dosage of anesthetic going in the medullary part and the more deeper part. And then we decide to cut the tooth. We will start to cut the crown, and it's always in these cases not so easy to create the correct separation between the coronal part and the roots, because the tooth is always oriented a little bit more different in respect to the OPG, to the panoramic X-ray. So we start removing the distal part of the crown, and we go in the pulpal cavity. Remember to feel the sensation that you fall as if you were performing a root canal. You feel the bore that falls in the pulpal cavity, and always remember to remain in the inner part of the tooth, so don't complete the separation lingually with your bar. And we try to go a little bit deeper on the root part as to reduce and remove the majority of interference before we tend to fracture the tooth with our lever. Always under saline cold irrigation. We see that we can work in a safe way on the buccal aspect. We are almost in the pulpal cavity and in the root part, so we are close to using the lever to separate and fracture the coronal aspect. So now we get our lever, we enter the separation, and we fracture the distal part of the crown, which could create an impaction in the vertical part of the ramus. After the luxation, we get a clemmer and we remove the distal part of the crown, and then with our blade we cut the soft tissue that was present in the distal pocket of this tooth 4.8. Lucas spoon, we remove the soft tissue completely, and this was the cause of the continuous infection that the patient suffered in the previous months. A thorough rinsage and washing of the tooth and of the cavity to see exactly where we want to start the luxation. And we feel that this luxation doesn't perform what we would like to have, which is a rotation of the mesial aspect of the root. And so we try on a buccal lingual side movement and also on a mesiodistal, and we see that we need more space, more working space, and so with a Fisher bar we create a little bit more space in order to have a little bit more playing movement of the root. And then we start to cut a little bit more the root, because we have to enter the root part in order to separate the distal part of the root from the mesial part of the root. And so we create a further cut of the tooth vertically in order to create this space. And so we see that we always remain on the buccal aspect of the tooth. And so we are cutting the tooth to try to reduce the friction of the tooth in the cavity. Our goal is to remove the tooth by removing the less quantity of bone and by reducing the luxating trauma. So we are continuously cutting the tooth with our Fisher bar. We know that we can cut the tooth also using piezoelectric instrumentation, but I suggest to do this just when we are close to important vital structures such as the inferior velar nerve, or in particular anatomical situation where we don't have the control of the bar. And so now we perform a second sectioning of the tooth, but we see that this is still not enough. It removes a little bit, a quantity of tooth, but it's still not enough to remove the coronal part and the root. So we have to see where we're going, and we need to go a little bit more apical on the root because the tooth was a little bit distal inclined, and so the roots were more mesial in comparison to what we saw radiographically. And once we see exactly the furcation and the separation inside the pulpal cavity, now we can start to create the correct separation of the area, and we can start luxating a little bit more the tooth, which we see that it's now moving more towards the distal aspect of the cavity. We see that the tooth is moving, but we always have to remember that the mesial root had a curvature, so always gentle movements. As I told you, I exited with my protector from the flap in order to avoid a laceration of the soft tissue, and now gentle movements to push and pull the root towards the distal aspect and from lingual to vestibular, but we see that this is not enough, so we decide to change the approach and to move the tooth a little bit more distally, and now we see that the tooth is actually moving a little bit more. And so once it reached the block position on the back, we start pushing it from buccal to lingual, but we see that we have to create a major working space, and so in this delicate area between the roots of the third molar that is going to be removed and the seventh tooth, the second molar, we go in with the piezoelectric saw as to create a major working space. And then we decide to cut a little bit more, furthermore, the root, because we don't want to create excessive forces to avoid fracturing the apical part of the root. So we cut the tooth as to reduce the friction of the tooth. We separate this part in two pieces, and now we have the root that manages to rotate and doesn't block on the buccal aspect, and we see the curvature of the root that we diagnosed preoperatively on our X-ray. And now we have to remove the distal part of the root, which is engaged in the bone. So we enter with our piezoelectric saw. We are quite deep and we feel more confident to work with the piezoelectric saw in this case to create a working space. We could also do it with a Fisher bar, and this depends obviously on our skills and our learning curvature, but with this kind of instrumentation we are much more confident. And so now we can luxate the distal part of the crown of the root from its location quite deep, and so gentle movements as to create a movement of the tooth from its position, and then with a clemmer we go and extract the apical fragment of the distal root. Now, when we think that the surgery is over, we always have to remember to check thoroughly our alveolus, our socket, to see that the bone is bleeding and that there are no fragments of soft inflamed tissue, especially in this case in the distal pocket that was present distally to the tooth. And also we have to completely check the distal aspect of the second molar to be sure that the soft tissue distally of the second molar is removed. So with our Lucas spoon, which is a cutting spoon, we create the correct cleaning of the area, and then with saline sterile solution we go and wash and completely rinse our socket our cavity, and then we're almost ready for our suturing procedures that in this case will perform a secondary healing closure and not a primary, because the tooth was erupted, so it was exactly in the arch in the mouth. So we see that we haven't created a laceration medially to the second molar, just because during the luxation procedures I've exited the flap and I kept the position much more free in the movement, avoiding the laceration with the lever. And now the closure of the distal part with the suture that goes from buccal to lingual and then from lingual to buccal. And then when we see that the knot is made and we're closing, we see that the soft tissue go and seal completely distally to the second molar. And this is the most important suturing point, to have a good closure and a good healing of the distal part of the second molar. And then we're going to close the releasing incision, deciding to keep the area where the tooth was erupted without being closed. So single stitches on the releasing incision, the first one, then the second one. Remember to engage enough tissue to avoid a laceration of the soft tissue. We have some inflammation, so there is a little bit of bleeding. And now we have recomposed the anatomy and we can give the dexamethasone shot in the buccinator muscle.